Madam, we are live.
Good evening, friends. We welcome you to all of you to the fifth episode of this season of Big Q. As you all know, that Brain Teaser is an online platform for hosting quiz for all the ophthalmologists of our country and Big Q for all the PGs across the country. So Brain Teasers in association with OSN presents Big Q. So this is the signature tune of Brain Teasers. And this is for you PG students.
आठ समंदर अपना अंबर खोज ले अब तू अपने दम पर भूख मार के धूल झाड़ ले छोड़ छाड़ के सारे छप्पर आठ समंदर अपना अंबर खोज ले अब तू अपने दम पर भूख मार के धूल झाड़ ले छोड़ छाड़ के सारे छप्पर खोल दे पर खोल दे पर खोल दे पर खोल दे पर बंद घड़ी की भी रुकी हुई सुई होती सही दो दफा चुप क्यों है रहना मन का तू कहना रोके चाहे हिचकियां खोल पर खोल पर खोल पर आठ समंदर
So we welcome all the mentors and all the students on this fifth episode of this season of Big Q. Today, Dr. Prashant Bavankure is a little bit busy, so he will join us in between. So as you all know, this is season 3, which is aired alternate Wednesdays at 8 p.m. So platform is Kahoot for both the teams and non-PG participants. Total, we will be playing 15 episodes. Out of these 15, 8 will be preliminary rounds, 4 quarterfinals, 2 semifinals, and 1 final. So these are the quiz masters for today's episode. So I'm extremely thankful to the team of quiz masters who have toiled hard to create a wonderful experience of learning with fun. For today's episode, we welcome Dr. Khushnut Sheikh Ma'am, Professor in Ophthalmology at Surat Municipal Institute of Medical Education and Research, Gujarat. Dr. Ankit Agrawal, Cornea and Phaco-refractive Specialist at Eye Clinic, Prayagraj. Dr. Anuradha Ma'am, Associate Professor, Minto Ophthalmic Hospital and Regional Institute, BMCRI, Bangalore. Dr. Abhiraj Kumar, CEO of Abhinam Eye Care and Retina Center, Solan. And last but not the least, Dr. Richa Pyare, currently practicing at Shroff Eye Center, Delhi. As we all know that such a mega project is not possible without a strong financial support from the pharma company. So for this, we thank Microvision team who has been our steadfast partner since last 3 years. Our sincere most gratitude to Ashok sir, Mr. Kumaran, Mr. Navneet, and all the field force of Microvision for all their support. We also thank Mr. Sai and Numerotech team for smooth and flawless conduction of the quiz, computation of the results, and all other backend work which goes behind every episode. So before I familiarize you all with the rules again, this is a promo from the Microvision team. So let's quickly see the format and the rules. Total preliminary rounds are 8. Best of the 5 performances will be calculated so that you can qualify for the quarterfinals. And today is the 5th episode. As you all know, you all need to log in from 2 devices. First screen is a live quizzing on the Zoom platform, and the second screen is the Kahoot to answer. Mentors are requested to log in from separate screen only on the Zoom platform. So in today's episode, there will be total 10 sets. Each set has 5 questions. You will get 10 seconds per question. There will be no negative marking, but it will be calculated on the basis of fastest finger first. These are the prizes which the PGs will get during the finals. We have the welcome gift and the gift for the mentors of the 6 winning teams. And these are the audience prizes per episode. So in the middle of the episode, we will declare the winners of the last quiz and also the audience prizes. So we request all of you to just type in the chat box so that at the end of the episode, we can promote you as a panelist and we can chat with you. So before starting with the quiz, there is a sample question for all of you. You check your voting pads. Following a controversial statement against our Prime Minister, tourism to which country or place is being boycotted? Your options are Maldives, China, Bhutan, Taiwan. And your time starts now. Yes, I know you must be knowing the answer. It's Maldives. So now we can start with the quiz. I welcome our first quiz master, Dr. Khushnood Sheikh ma'am. She is a professor in ophthalmology at Surat Municipal Institute of Medical Education and Research, Gujarat. She has done her medical retina at Madurai. She has a clinical experience of 31 years and teaching experience of 23 years. And she is a resource person for medical education unit. I request everyone to please mute. Dr. Naina, please mute. Hand over. Khushnood ma'am.
Yes, good evening, Dr. Shilpi. Thank you very much. Am I audible?
Yes, ma'am, you are audible.
Good evening, Dr. Shilpi and every participants. And best of luck from my side to each and every participants. So, shall we proceed with the questions? The question 1 is, a newborn infant presents with this finding. What developmental anomaly caused this presentation? Your options are incomplete closure of embryonic fissure, faulty migration of the neural crest cells. Option C, exuberant proliferation of the glial tissue. And option D is abnormal retinal differentiation. Your time starts now. And the answer is incomplete closure of the embryonic fissure. So it is a chorioretinal coloboma. These types of coloboma involve the optic nerve, choroid, retina, and iris. And it occurs because of the faulty migration of the neural crest cells, which results in the anterior segment dysgenesis. We'll proceed to the second question. A 2-year-old child, infant, present with this finding, a developmental anomaly occurred during which stage of the ocular embryogenesis? Your options are A, 6th week, B, 3rd month, C, 5th month, and D, 8th month. Your time starts now. And the answer is 5th month. This occurs during the 6th week of gestation. Eyelid fold begins to develop. During the 3rd month, eyelid fold lengthen and fuse, and the separation of the upper and lower lid occurs during the 5th month. This patient has the ankyloblepharon, which occurs due to incomplete separation of the upper and lower eyelid. We'll proceed to the 3rd question. The patient has normal vertical eye movements. Left eye developed the left jerky nystagmus on attempted left gaze. Where is the most likely location of the causative lesion? The options are left paramedian pontine reticular formation, right third nerve nucleus, left medial longitudinal fasciculus, and the right medial longitudinal fasciculus. Your time starts now. And the answer is right medial longitudinal fasciculus. The explanation to this is, this image shows the normal horizontal movement of the left eye and poor adduction of the right eye. Combination of the abnormal adduction and contralateral abducting nystagmus represents an internuclear ophthalmoplegia. Here, the damage has occurred at the interneuron, correcting the left sixth nerve nucleus and the right third nerve nucleus, traveling in the right medial longitudinal fasciculus. This can be the third nerve palsy if it would have involved the other recti muscles, and damage to the left parapontial radicular formation results in the left gaze palsy. Our next question is, a 3-year-old girl presents with the shown lesion. All of the following statements are true, except this lesion is anterior to Bowman's membrane and can be scraped off without concern of stromal involvement. Second option is, associated finding include preauricular skin tags, upper eyelid coloboma, and vertebral anomalies. Often there is an associated arc of lipid in the cornea in advance of the lesion. And the last option is, these lesions may have hair follicles or sweat gland in. Your time starts now. And the answer is, this lesion is anterior to Bowman membrane and can be scraped off without concern of stromal involvement. That is the exception. And the explanation to this is, this is the hematomatous lesion. It consists of the fibrofatty tissue surrounded by the keratinized epithelium, which often contains the hair follicles, sebaceous glands, and sweat glands. It is usually located at the inferior-temporal limbus. It is associated with the lipid in the corneal stroma surrounding the edge of the lesion. Large dermoids can cause astigmatism and amblyopia. Excision may be difficult because they may involve the Bowman layer and corneal stroma, and as a result, it causes the postoperative scarring, astigmatism, and amblyopia. Our next question is, a 64-year-old white woman presents with the complaint of pain, decreased vision, and a red eye for the past 2 days. Her medical history reveals that she had a trabeculectomy for primary open-angle glaucoma in the same eye 6 months before. What would a gram stain of the vitreous fluid of this patient most likely show? The options are gram-negative cocobacilli, gram-positive rods, branching pseudohyphal forms, and gram-positive cocci in clusters. And your time starts now.
మర్చిపోయావా అప్పుడు? మళ్ళా తర్వాత పాపం యూపీఐ వర్కింగ్,
And
యూపీఐ
the
వర్కింగ్
Dr. Preeti,
answer is
unmute yourself. Dr. Preeti. Ma'am, we can go ahead.
yes. And the answer is gram-negative cocobacilli. And the explanation to this is the most common organism is responsible for Streptococcus species and Haemophilus influenzae. Other organisms such as Streptococcus epidermidis and gram-negative species have been implicated less frequently. And the fungal causes are also rarely associated with the filtering bleb associated endophthalmitis. Our next speaker is Dr. Ankit Agrawal. Our next quiz master is, Dr. Ankit Agrawal is a cornea and phaco-refractive specialist. He is running his clinic at Prayagraj. He has experience of over 7,000 phaco surgeries in private practice. He has presented many free papers, posters, and he has invited talks at various national and international conferences. He has received SD Atwale Award in AIOC 2018 and Best Paper Session Award in 2021 at DOS International Hybrid Conference. He has a special interest in disseminating the tips and tricks of phacoemulsification to young and budding surgeons through presentations, and he makes the YouTube surgical videos too. So, I'm inviting Dr. Ankit Agrawal for his quiz.
Thank you, Kushnur ma'am. Coming to the first question. What is not the differential diagnosis for this finding? The options are Fabry disease, amiodarone use, hepatic failure, and chloroquine use. The time starts now. The answer is hepatic failure. So this is also known as vortex keratopathy, Fleischer's vortex, or cornea verticillata. Most commonly caused by amiodarone, but may be associated with Fabry disease, chloroquine use, hydroxychloroquine, endomethacin, and phenothiazines. Few other causes include multiple sulfate deficiency, neurotrophic keratitis, and Lisch corneal dystrophy, etc. But hepatic failure is not associated with this kind of finding. Coming to the next question. Patient presented with persistent headache and transient diminution of vision since few months. What may be the most appropriate cause of findings in the image shown? The options are accelerated hypertension, elevated ICP, head trauma, or all of the above. Time starts now. The answer is elevated ICP. So this is a classical case of papilledema where it is an optic disc swelling that is secondary to elevated intracranial pressure. In contrast to other causes of optic disc swelling, vision usually is well preserved in acute papilledema, but transient diminution may occur. They always present as bilateral and may develop over few hours to few weeks. We have to rule out intracranial masses and malignant hypertension to rule out other causes which may be associated with ICP rays. Coming to the next question. Which of the following is false regarding the findings seen in this image? The options are can be caused due to Marfan's syndrome, rosette cataract, treatment includes iododialysis repair and cataract extraction. Fundus findings may include retinal breaks or tears. The time starts now. The correct answer is can be caused due to Marfan's syndrome. So this is a image which shows what is sequelae to blunt trauma to the eye, where iris sphincter tears, lens subluxation or dislocation, and rosette cataract formation occurs. Corneal endothelial damage, vitreous prolapse in anterior chamber, or vitreous hemorrhage, or retinal breaks and tears, especially in the peripheral retina, can occur in a blunt trauma. Coming to the next question. Which is the finding associated with this image? The options are acute loss of vision, severe headache, altitudinal field defect, or none of the above. Time starts now. The correct answer is none of the above. All these three options are wrong. The normal tension glaucoma is a common form of primary open-angle glaucoma in which there is no measured elevation of the intraocular pressure above normal. So, what was positive about normal tension glaucoma is in this image, that is a flame-shaped hemorrhage on the optic nerve rim was present, also known as trans hemorrhages. A deep focal notching of the rim and peripapillary atrophy can be seen. Coming to the next question. Which of the following is correct regarding this kind of cataract? Options are: it is swelled due to increased water influx, intralentricular pressure is more than the anterior chamber pressure, Argentina flag sign may occur during capsular access, or all of the above. The time starts now. And the correct answer is all of the above. So this is the intumescent cataract in which interventricular pressure has increased more than the anterior chamber pressure due to failure of sodium potassium pump, causing increased water influx. In these kind of cases during capsulorhexis, Argentina flag sign may occur. The safe methods of doing capsulorhexis in these kind of cataracts include needle aspiration of cortex, double rhexis, spiral rhexis, and puncturorhexis. Now, I welcome the next quiz master, Dr. Anuradha A., who is an associate professor as Minto Ophthalmic Hospital and Regional Institute, Bangalore. She has a work experience of 14 years in teaching undergraduates and postgraduates, and she has a specialization in glaucoma and cataract surgeries and a special interest in ocular trauma management. She has presented multiple papers and journal articles at various forums and is a life member of AIOS, GSI, KOS, and BOS. We welcome you, ma'am.
Thank you, Dr. Ankit. So we will move on to next section, that is section 3. The first question is, all the structures are derived from surface ectoderm, except the options are lacrimal glands, B, tarsal glands, C, lens, D, extraocular muscles. And your time starts now. And the answer is D, extraocular muscles. Extraocular muscles is the only structure here which is derived from mesoderm, and the rest are derived from surface ectoderm. Moving on to the question 3.2. Which eye disease contributes to maximum proportion and stands first in cases of blindness as per WHO reports worldwide? Option A, cataract. Option B, glaucoma. Option C, diabetic retinopathy. And option D, trachoma. Your time starts now. And the correct answer is cataract, which contributes to 43% according to global data worldwide. Coming to question number 3.3. The first sign of spread of cavernous sinus thrombosis to the other side is option A, fever. Option B, proptosis. Option C, papilledema. Option D, paralysis of the opposite lateral rectus muscle. Your time starts now. And the correct answer is paralysis of the opposite lateral rectus muscle, which is a sign of bilateral involvement, the spread to the opposite side. Now coming to the next question, 3.4. Following conditions can present as intracorneal lesions except option A, cavernous hemangioma. Option B, optic nerve glioma. Option C, arteriovenous malformations. And option D, thyroid ophthalmopathy. Your time starts now. And the answer is thyroid ophthalmopathy. It generally involves the extraocular muscle bellies. Coming to the next question, 3.5. Ptosis and failure of convergence are early and prominent features in which of these diseases? Option A, myogenic ptosis. Option B, myasthenia gravis. Option C, neurogenic ptosis. Option D, aponeurotic ptosis. And your time starts now. And the answer is answer B, myasthenia gravis. Failure of convergence is an early and a prominent feature in myasthenia gravis, along with ptosis. So this is the answer. So next we have quiz master Dr. Abhiraj Kumar. Dr. Abhiraj Kumar is a CEO of Abhinam Eye Care and Retina Care in Solan. He has and also Tenzin Eye Hospital Shimla, Drishti Hospital Panchakula. He did his graduation, did his post graduation from PGI MER Chandigarh, and he has best papers in AO October 2014, Premchand Award for best paper, and best challenging case in 2014, and best challenging case Chandigarh Ophthalmological Society. Over to you, Dr. Abhiraj.
Abhiraj sir.
Thank you, Anuradha ma'am. Next, move to the next session. Section 4. My first question is subretinal hyperreflective material diagnosed by OCT as a hyperreflective band of material present in which type of macular neovascularization? The options are type 1 MNV, type 2 MNV, type 3 MNV, or type 1 and 3 MNB? Your time starts now. The answer is type 2 MNB. The explanation for this is the subretinal hyperreflective material, which is diagnosed as OCT, as a hyperreflective band of material present in subretinal space that can represent type 2 MNB. It can be present at the subretinal fibrosis, subretinal fibrin, subretinal HAMS, or vitiliform lesion. Octa can add and distinguish the various form of SHRM. The next question is, IRORA may be provide an early stage of intervention in the therapeutic trial of. The options are diabetic macular edema, juxtafoveal telangiectasia, geographical atrophy, or CRVO and CME. Your time starts now. The answer is geographical atrophy. The explanation for that is the CAM group has devised an OCT classification system of atrophy of AMD that may provide the earlier landmark for intervention of the therapeutic trial for geographical atrophy. The CRORA is a complete RPE and outer retinal atrophy, whereas the IRORA is defined as the incomplete RPE and outer retinal atrophy. The IORI is a OCT stage which can still occur in absence of the corresponding fundoscopic or autofluorescent evidence of geographical atrophy. So the IRORA may provide an earlier stage of intervention in a therapeutic trial for the geographical atrophy. And my next question is, on OCT, DREAL refer to the loss of normal anatomical lamination of which layer of retina? The options are inner layer, middle layer, outer layer, or inner and middle layer. Your time starts now. The answers for this is inner and middle layer. The explanation of that, the DREAL is known as the disorganized retinal inner layer, is a predictive OCT biomarker of the visual acuity in an eye with DME. DREAL refer to the loss of normal anatomical lamination of the inner as well as middle retina with OCT that correlate with the poorest visual acuity and can be related to predict the visual outcome. My next question is, paracentral acute middle maculopathy refer to the involvement of which cell layer of the retina? The options are nerve fiber layer, ganglion cell layer, inner nuclear layer, or outer nuclear layer. Your time starts now. The answer is inner nuclear layer. The explanation of that is the OCT image provide in vivo view of the retinal structure after central retinal artery occlusion. There is an increased reflectivity of inner and middle layer because of the corresponding ischemia of nerve fiber layer and ganglion cell layer. That is the inner retina. And the inner nuclear layer, that is the middle retina. So acute CRAO can be associated with the only hyperreflectivity of the middle layer, that is inner nuclear layer, referred to as a paracentral acute middle maculopathy. This OCT finding can be the only sign of CRAO in some cases and therefore very important to identify. My next question is, in 2018, short-term trial by DRCR investigation, which protocol evaluate the effect of adding the dexamethasone 0.7 milligram intravitreal insert as an adjunct to the ranibizumab 0.3 milligram injection for persistent DME. Your options are protocol I, protocol T, protocol B, or protocol U. Your time starts now. The answer is protocol U. The explanation for that is, in 2018 short-term trial for DRCR investigation, evaluate the effect of adding dexamethasone with the ranibizumab adjuvant in the injection of the persistent DME. We saw there's a modestly greater reduction in the retinal thickness in a co-treated eye, but there is no difference in the gain of the visual acuity as compared with the eye with the treated with a ranibizumab alone. With this, I welcome my next quiz master, that is Dr. Richa Pyare, who is currently practicing at Shroff Eye Center. She had done her MBBS from Lady Hardy Medical College, New Delhi, and done her MS from Maulana Azad Medical College, New Delhi. She did her fellowship from Sankara Nethralaya, Chennai. She also did fellow of International Council of Ophthalmology. She had several peer review publication and presented multiple paper and cases in national as well as international conferences. Over to you, ma'am.
Thank you, sir. Yeah, thank you, sir. So let's start the next section, the section 5 of this quiz. The first question is, if you see this picture, the next step would be 1, you proceed with intravitreal anti-VEGF injection.
Hello, Harif.
Hello? Can you hear me? B, investigate for possible ocular tuberculosis and start oral steroids. C, start systemic antivirals followed by oral steroids. And D, investigate for HIV. Your time starts now. The correct answer is start systemic antivirals followed by oral steroids. And the explanation for this is that the fundus picture is actually acute retinal necrosis. It typically affects otherwise healthy individuals. The diagnosis is clinical, and you can confirm your findings on using vitreous or AC tap. Management is systemic antivirals with intravenous acyclovir or oral valacyclovir with systemic steroids, which can be added after 24 hours of systemic antivirals. Okay, moving on to the next question. Vitreous particles of asteroid hyalosis are composed of A, cholesterol, B, amyloid, C, calcium, and D, hyalin. Your time starts now. All right, and the correct answer is C, calcium. Okay, and the explanation is that this is asteroid hyalosis are calcium lipid complexes which are suspended throughout the collagen fibrils of the vitreous. Moving on to the next question, the third question of this round. Which pathogen is associated with the development of Kaposi sarcoma? And your choices are A, human herpes virus 4, B, human herpes virus 8, C, herpes simplex virus type 1, or D, cytomegalovirus. And your time starts now. All right, time's up. And the correct answer is human herpes virus 8. Okay, so human herpes virus 8 is associated with development of Kaposi sarcoma in humans. Moving on to the next question. Birdshot chorioretinopathy is associated with A. The choices are A. Can we move the slide? HLA-B27, B. HLA-DR4, C. HLA-A29, or D. HLA-B51. And your time starts now. All right, time's up. And the correct answer is HLA-A29. Okay, so all of these different HLAs are associated with different disease entities, like HLA-B27 is associated with ankylosing spondyloarthritis and anterior uveitis. HLA-DR4 is associated with VKH. A29 is associated with birdshot chorioretinopathy, and HLA-B51 is associated with Behçet's. Moving on to the next question. What should be the next step in the management of this patient be? And your choices are A, urgently start systemic antiviral therapy. B, get an optical coherence tomography and plan for intravitreal anti-VEGF injection. C, plan for intravitreal TPA and gas injection. Or D, plan for an electrooculogram. And your time starts now. All right, time is up, and the correct answer is D, plan for an electrooculogram. So the fundus picture shows a case of Best vitelliform dystrophy. In this, typically the electrooculogram is universally abnormal with an Arden ratio of 1.5 or less, and an ERG is usually normal. Moving on, I think we'll go on to the next section.
We are over with the first set of the questions. So this is time for commercial break. This is a video from Microvision team. So now we are declaring the result of the last episode, that is episode 4. So congratulations to all the winners of the episode 4. So these are the episode toppers and the private practitioner winners. So request everyone to please type in the chat box so that we can let you in at the end of the episode. So with this, we move to our next section with Dr. Khushnud ma'am. Dr. Khushnud ma'am. Dr. Khushnud ma'am, are you there?
Yes, ma'am. Hello.
Shall we start?
Just a minute, ma'am, please.
Yeah.
Just a minute. Yes, ma'am, I can start, but my computer is not getting started. So the problem is in the mobile, I cannot see the lower the options. So that is why I need to see in the this thing laptop.
Okay. Shall I help you in that?
Ma'am, my computer is not getting started because it has rebooted. That's why. So
Okay.
how can you, ma'am, if it is possible, if you can, I'm
Yeah,
starting.
you can
Yes.
two options you are seeing now.
Yes. In the
You can
mobile, I'm
start
seeing.
with the question. I'll read
Yes.
the options. Okay, ma'am.
Okay. Yeah. Just it has started also, so I can start also. No problem. But if
Okay.
I don't speak, you just continue, please.
Sure. So shall we start?
Yeah, ma'am. Yes. Thank you. So the our next section is section 6, and the question number 1 is: a patient presents with the eye shown in the picture. All of the following condition can cause this, except. The options are
A. Uveitis glaucoma hyphema, that is UGH syndrome. Option B. Herpetic iridocyclitis. Option C. HLA-B27 anterior uveitis. And option D. Traumatic iridocyclitis. And your time starts now. Yes, the time is up. And the correct answer is
HLA-B27 anterior uveitis. And the explanation to this is this patient has a severe anterior uveitis with hyphema. Any severe uveitis can cause damage to the iris vasculature, resulting in anterior chamber bleeding, in particular varicella zoster virus, iridocyclitis, and HLA-B27. Traumatic injury can cause a tear at the iris root in addition to inciting an anterior uveitis. Dispersed blood and fibrin can appear similar to the active uveitis. UGH syndrome is the result of the movement of an anterior chamber intraocular lens, which shapes the iris and angle, causing the inflammation and bleeding. So this patient is phakic, therefore this etiology is not possible. Move on to the second question. A 34-year-old lawyer is struck in the eye by a golf ball launched by an ophthalmologist. The ophthalmologist rushes the lawyer to his office and examines his eye. 20% of hyphema is present in anterior chamber. No rupture of the globe is present. Traumatized eye is at risk for developing all of the following types of glaucoma, except option A, angle closure glaucoma, option B, open angle glaucoma, option C, angle recession glaucoma, and option D, phacolytic glaucoma. Your time starts now. And the answer is phacolytic glaucoma. Blunt trauma may produce angle recession glaucoma, a form of secondary open angle glaucoma. Contusion and hyphema can eventually cause the formation of peripheral anterior synechia with the development of chronic angle closure glaucoma. Phacolytic glaucoma develops from the obstruction of the trabecular meshwork by macrophages laden with the lens material leaking from the mature lens. Our next question is: which one of the following statements regarding the clinical condition found in this 73-year-old woman is true? Option A: biopsy of the adjacent conjunctiva may show increased plasma cells. Option B: corneal proliferation will occur rapidly. Option C: systemic immunosuppressive will be necessary. And option D: it is a painless, slowly progressive process. Your time starts now. And the answer is biopsy of the adjacent conjunctiva may show increased plasma cells. And the explanation is to this is it is a Murray's ulcer. Conjunctival injection, ulceration of the peripheral cornea and undermined leading edge. Pain may be severe and accompanied by the photophobia. An autoimmune process likely plays a role as immunoglobulin complement and plasma cells are found in the adjacent conjunctiva. Our next question is, an elderly patient underwent an uncomplicated trabeculectomy of right eye. Next day, intraocular pressure was 1 millimeter of mercury, and the patient has this slit lamp appearance. The blab is flat, the retina and choroid appear normal. What is the most likely cause of this finding? Your options are malignant glaucoma, choroidal detachment, blab leak, excessive filtration. Your time starts now. And the answer is excessive filtration. So often there is a unrecordable intraocular pressure is common during the early postoperative period and is typically associated with the shallow anterior chamber. If there is an obvious hole in the conjunctiva, one would see positive Siddle test. And the treatment to this is the spontaneous closure with the pressure patch or the scleral compression shell can be used. Other treatment options are defect suturing or trichloroacetic acid, soft contact lens, and autologous blood injection. Fluid commonly gets collected in the suprachoroidal space in hypotonous eye, leading to the serous choroidal detachment. Our next question is, which one of the following organism is capable of traversing intact corneal epithelium and establishing bacterial keratitis as shown? The options are Staph aureus, option B, Staph epidermidis, option C, Pseudomonas aeruginosa, and option D, Haemophilus influenzae. The time starts now. And the answer is H. influenzae. Explanation to this is, this clinical picture caused by many bacteria such as S. aureus, S. epidermidis, and Pseudomonas aeruginosa. Most bacteria require a break or disruption of the corneal epithelium to gain the access and subsequent adherence to the underlying cornea. Haemophilus is one organism that can invade the intact epithelium and establish the infection. Other bacteria that do not require epithelial disruption include spurious, Corynebacterium spurious, and Listeria species. So that is about the. Now we will proceed to the section 7.
Dr. Ankit?
Yeah, coming to the first question of section 7. In the image shown, what is the most appropriate term for this disease? The options are intumescent cataract, immature cataract, Morganian cataract, or traumatic cataract. Time starts now. The correct answer is Morganian cataract. The explanation to this is Morganian cataract is a form of hypermature cataract formed by liquefaction of the cortex and sinking of dense nucleus to the bottom of the capsular bag, named by Giovanni Battista Morgagni in the 18th century. Coming to the next question. A patient presents with progressive painless loss of vision in the right eye and this appearance on examination and MRI. What is the most likely diagnosis? The options are pituitary adenoma, papilledema, retrobulbar neuritis, and optic nerve sheath meningioma. Time starts now. The correct answer is optic nerve sheath meningioma. These are uncommon benign neoplasms originating from the meningoendothelial cells of the meninges surrounding the optic nerve. The tumor may arise from either the intraorbital or intracanalicular portions of the optic nerve where there is a meningeal sheath. Symptomatic patients most often present with gradually progressive painless monocular vision loss. A few patients may demonstrate a classical clinical triad, which include painless, slowly progressive vision loss, optic atrophy, and optociliary shunt vessels. Coming to the next question. Please move the slide. Next question, please.
Sir, I have already moved the slide.
It's not showing in mine. Yeah, okay, it's here. A 40-year-old male presents with blurry vision and photophobia. He was found to have bilateral hilar lymphadenopathy, rashes on trunk and legs, and an elevated ACE level. What is the diagnosis? The options are HLA-B27 associated sarcoidosis, tuberculosis, and roseola. The time starts now. The correct answer is sarcoidosis. So, the explanation is it is a systemic inflammatory disease of unknown etiology characterized by formation of non-caseating granulomas, most commonly affecting skin, lungs, lymph nodes, and eye. Most common ocular manifestation is uveitis, and most common type is bilateral anterior uveitis. Slit lamp shows iris nodules, anterior and posterior synechiae. Vitreous shows snow banking and snow banking and intermediate uveitis present. Posterior involvement is usually bilateral but can be asymmetric, and candle wax drippings, that is scattered whitish yellow perivascular and retinal exudates, can be seen along the retinal veins. Coming to the next question. This is the corneal image of a post-keratoplasty patient. Which of the following is not true? The options are infective keratitis following penetrating keratoplasty, Kodados line is present, graft rejection due to ill-fitting graft, loose sutures causing corneal neovascularization. Time starts now. The correct answer is infective keratitis following penetrating keratoplasty. So, the white line which you see is the Kodados line, which is an indicator of endothelial ejection. This ejection line is made of white blood cells on the endothelium and usually begins in one region of the cornea and progresses across the endothelium over time. The Kodados line in this patient began inferonasally and has migrated to the superior cornea. The region inferior to the Kodados line is more edematous and hazy than the cornea superior to the Kodados line. Now, coming to the next question. Which is this finding caused due to? The options are anterior uveitis and posterior synechiae, persistent pupillary membrane, blunt trauma to the eye, or iatrogenic. The time starts now. The correct answer is persistent pupillary membrane. It is a frequently encountered congenital anomaly. It represents remnants of anterior tunica vasculosa lentis and appears as strands of connective tissue bridging the pupillary area. They are usually asymptomatic and of no functional significance. In rare cases, dense membranes can persist and obscure the pupil, causing amblyopia. The remnants of pupillary membrane are seen in about 95% of neonates and 20% of adults and are more common in premature babies. Coming to the next section, that is section 8.
Anuradha ma'am.
Yes, Dr. Shilpi. Thank you, Dr. Ankit. Now we go to section 8. The refractive index of vitreous humor is, the options are A 1.336, option B 1.000, option C 1.376, option D 1.406. Your time starts now. And the correct answer is option A 1.336. These are the various refractive index of each component of the eye. Aqueous humor and vitreous humor having a refractive index of 1.336. Now going to the next question. In the presence of complete third cranial nerve paralysis, the function of fourth cranial nerve, that is the trochlear nerve, is assessed by instructing the patient to attempt looking option A upward, option B downward, option C laterally, and option D medially. Your time starts now. So the right answer is answer B, that is downward. We generally ask the patient to look straight downwards and we observe for intorsion, which is by the action of superior oblique muscle, which is supplied by trochlear nerve. Going on to the next question. All are epithelial and subepithelial dystrophies of cornea except option A, Thielbeck's corneal dystrophy, option B, epithelial basement membrane dystrophy, option C, Niesman corneal dystrophy, and option D, gelatinous drop-like corneal dystrophy. And your time starts now. And the right answer is option A, Thielbeck's corneal dystrophy. This is a dystrophy which comes under Bowman's layer dystrophy. Going on to the next question. Identify the valveless MRI compatible stent used for treatment of glaucoma. Option A, iStent. Option B, Express Mini Shunt. Option C, Trabectome. Option D, Solex Gold Stent Shunt. Your time starts now. And the right answer is option B, Express Mini Shunt. Though it is made up of stainless steel, it is still proved by many studies that it is safe for under MRI. Coming to the next question. The tonometer that estimates IOP most independently of central corneal thickness and is ideal for use in LASIK thinned corneas is option A, dynamic contour tonometer, Option B, applanation tonometer. Option C, tonopen. Option D, pseudotonometer. And your time starts now. And the right answer is option A, dynamic counter tonometer. This is a tonometer which is least affected by the corneal biomechanics, and that is how it is useful in corneas which are thinned out by LASIK procedure. So we go on to next section by Dr. Abhiraj.
We move to the next section, section 9. My first question is, the Vibrant study was a double mass active controlled randomized multi-center phase 3 trial. The options are ARMD, diabetic macular edema, CRVO, VRVO. Your time starts now. The answer is VRVO. The Vibrant studies compare the safety and efficacy of the intravitreal aflibercept versus macular bead laser in the treatment of the macular edema from VRVO. In this study, they found out that the intravitreal aflibercept groups had achieved the more visual acuity as compared to the laser group. And this is the Vibrant study was the first trial to compare the anti-VEGF therapy directly with the laser. And the results were strongly favor of the aflibercept with similar side effect profile in both groups. My next question is, the two double mask randomized prospective phase 3 trial, that is name is the Copernicus and Galileo, and has investigated the role of which intravitreal drug. The options are aflibercept, ranibizumab, bevacizumab, or dexamethasone implant. Your time starts now. The answer is aflibercept. The explanation for this is the two double mask randomized prospective trial, that is Copernicus and Galileo, enroll eye in a case of CME associated with the CRVO. The Copernicus study in the United States, where the Galileo was studying Asia Pacific region and Europe, and they found out that both the study, the visual gain, that is more than 15 letter, is more in the aflibercept group as compared to the sham group. Based on this study, aflibercept received the FDA approval for CME secondary to CRVO in 2014. Our next question is, the LEVO trial include, the options are triamcinolone, dexamethasone implant, both, or none of the above. Your time starts now. Answer for this is none of the above.
Sir, we can't hear you.
Ma'am, you are not really able to hear me?
Yeah, its voice is little bit okay. Now it's okay, sir.
It's okay. The explanation for this is The liver study the drug like Lucentis, Eylea, Avastin, and the study done in the United Kingdom, where they found out that the aflibercept group gain more visual acuity, and it causes greater reduction of the central macular thickness as compared to the bevacizumab group and ranibizumab group. My next question is, the phase 2 stay away trial and Onyxi study was done for which drug? The options are bevacizumab, dexamethasone, both, or none. Your time starts now. The answer for this is none. None of the above. The explanation for this is the stay-away study did the trial compare the intravitreal injection of faricimab with the ranibizumab, where the Onyxi study the drug nevasumab with the aflibercept. So the answer is none of them. My next question is, Food and Drug Administrations added warning level to which hypoglycemic drug about the possibility that use of that drug for longer than a year may be associated with increased risk of the bladder cancer. The options are metformin, glimepiride, pioglitazone, or liraglutide. Your time starts now. The answer is pioglitazone. The explanation for that is the thioglycazone are the agonists of PPARG, and it primarily enhances the insulin sensitivity of a muscle's fat and the milieu of the liver. It also lowers the fasting and the postprandial glucose level. The side effects include weight gain with increase in the subcutaneous adiposity and fluid retention. It has been shown to be associated with an increased risk of fracture, particularly in women. In June 2011, the US Food and Drug Administration FDA added a warning to the pioglitazone level about the possibility that the use of pioglitazone for longer than a year may be associated with the increased risk of bladder cancer. So for that, we move to the next section. Over to you, Dr. Richa.
Thank you, sir. So moving on to the next question. A 26-year-old myopic female patient walks into the OPD with complaints of photopsia and mild drop in vision, with a quiet anterior chamber and vitreous. On fundus examination, several small yellow-white macular spots with fuzzy borders were noted. The autofluorescence photo is shown. These findings are consistent with, your choices are A. Can we move the slide, please? A. Azure. B. Serpiginous choroiditis. C. PIC. Or D. AMN. Your time starts now. The time is up and the correct answer is C. PIC. The explanation for this is punctate inner choroidopathy. It typically affects young myopic women in which the anterior uveitis and vitritis are usually absent or very mild. Fundus shows several small yellow-white macular spots with fuzzy borders at the level of inner choroid and retina. And these evolve into sharply demarcated atrophic scars with little pigmentation. Diagnosis is based on clinical examination. Active lesions are hyperautofluorescent. So moving on to the next question. A patient presents to the OPD after blunt trauma with a cricket ball and a drop in vision to 660. On examination, the pupillary reactions are normal. The intraocular pressure is 16 millimeters of mercury. The anterior chamber is formed and shows no cells of flare. On fundus examination, there is a yellow sheen-like appearance of the macula. What is the appropriate next step in management? And your options are A, to observe, B, a high dose of corticosteroids, C, urgent anterior chamber tap, or D, laser photocoagulation. And your time starts now. And the correct answer is A, to observe. The explanation, these findings are consistent with commotio retinae, and the appropriate management is observation only. Moving on, the next question, the third question in this section, band keratopathy is a corneal degeneration that is most often composed of fine dust-like calcium deposits in which layer? And your options are A, epithelium, B, Bowman's layer, C, Descemet's membrane, or D, the endothelium. And your time starts now. All right, and your time is up. The correct answer for this is B, Bowman's layer. The explanation is that band keratopathy is a corneal degeneration which is with calcium deposits in subepithelium, Bowman's layer, and the anterior stroma. Okay, moving on to the second last question. A 43-year-old woman presents with acute onset pain, redness, and drop in vision in both eyes. On examination, the anterior chamber is shallow in both eyes with raised intraocular pressures. She has a history of migraine and has recently been started on a new drug. Which is the likely new drug she has been started on? And your options are A, amitriptyline, B, topiramate, C, almotriptan, and D, acetaminophen. And your time starts now. And the time is up. The correct answer is B, topiramate. And the explanation is this lady has been started on topiramate, which can result in acute angle closure glaucoma secondary to swelling of the ciliary body. Moving on to the final question of this section. This is a visual connect question. So you can see two pictures on the screen. Connect these two pictures to form the name of the disease entity. And this disease entity will present as, your options are A, multiple nevus-like choroidal lesions, B, attenuated arterioles, optic disc pallor, and mild RPE changes, C, round orange-red mass, or D, solitary elevated subretinal gray-brown dome-shaped mass. And your time starts now. Your time is up, and the answer is this A, multiple nevus-like choroidal lesions. Now, the explanation is the two pictures were B plus dump, BDUMP, BDUMP, which presents with multiple nevus-like choroidal lesions. Bilateral diffuse uveal melanocytic proliferation is a paraneoplastic ocular syndrome. And this occurs in patients with systemic occult advanced carcinomas and is a hallmark of poor prognosis. It is characterized by proliferation of benign melanocytes in the outer choroid, which causes the formation of these multiple nevus-like choroidal lesions. With this, we conclude this section of our quiz. Thank you.
Thank you. Thank you, all the quiz masters, Dr. Khushnood ma'am, Ankit sir, Anuradha ma'am, Viraj sir, and Dr. Richa. So, Sai, have we let us
Yeah, I'm letting them in.
in? So we have Pramila madam with us. Dr. Pramila ma'am. Dr. Vijay Varshini ma'am. Dr. Somil Jain. Can you please unmute? Dr. Inchera. Dr. Suviksha ma'am. Dr. Purvasha. Yes, Suviksha and Padmavan. Good evening.
Good evening.
So you are at which place?
We came first, ma'am. First.
First. Anuradha ma'am.
Hi, yes, Shilpi.
Ma'am, these
Hi.
are the winners of the last episode.
Oh, great, great. Congratulations, both of you.
Thank you, ma'am.
So from where are you?
We are from Coimbatore Medical College, ma'am. Tamil Nadu, Coimbatore Medical College, ma'am.
Okay. Ma'am, you want to ask anything?
Okay, great, girls. How are you preparing?
Just reading Kansky and Aravind FAQ book, ma'am.
Okay, that's really nice.
Thank you, ma'am.
I
So
requesting
you're
everyone to please switch on the videos. Yes, ma'am, you can.
yeah, what are your names?
Ma'am, I'm Subiksha, ma'am. This is my teammate, Dr. Vinodini, ma'am.
Which year are you people in? Sudiksha
Final.
and Vinodini? Final year.
Yes, ma'am.
Oh, good luck, good luck. Please read monograms.
Yes.
Whatever you're reading is really good, but if you read monograms, you'll get more insight into each subject.
Okay.
Okay. Good luck,
Thank you.
girls.
Thank you, ma'am.
Congratulations. So
Thank you.
next is Dr. Inchara, Dr. Aparna, so Dr. Purvasha, what to say?
It's really nice to see people from all around the country participating and then, showing, getting prizes for each episode. I think the zones change. Isn't that so, Shilpi?
Few are, always there in the list. So,
I think it's going to be difficult for you to compile all the results.
yeah, it's always like it's very, it's a difference of only few marks, basically. And yes, it also depends upon the network issue, the speed. It's
True.
not about only the knowledge.
Right.
Exactly.
Many factors.
Yes.
I think consistency is important.
Hello, ma'am. Is it
Yes, ma'am.
Inchera?
Ma'am.
Did you call Inchera?
Yes.
Okay. That's me. Hello.
Yes, ma'am. Yes. So, ma'am, you are from which place?
Yeah, I'm from Devarajas Medical College, Kolar, Karnataka.
Okay. Okay, ma'am. Okay. So you are amongst the private practitioner group or a mentor of any team?
No, mentor. I'm mentoring my two final year PGs.
Okay, ma'am. Okay, ma'am.
Thank you, ma'am.
So how you feel about the quiz? What about the
Yeah,
questions?
we eagerly wait for this week every 15 days, and it's very nice, ma'am. It's like really good. The questions, the quiz masters and all, very nice.
Thank you, ma'am. Thank you.
Thank you.
Thank you, Inchira. Thank you so much.
Hi,
Dr.
ma'am.
Aparna KS.
Hi, Dr. Inchira.
Yes, ma'am. I'm Dr. Aparna KS.
Yes, ma'am. You are on the second place, I think. no?
Yes, ma'am. Last episode, second place.
Okay. Dr. Khushnu, ma'am, she is from the private practitioner group. I think ma'am is not there.
Hello, ma'am. Yes, I'm here.
Okay.
Yes.
Ma'am, you can chat with the ma'am for a while.
Yes, many congratulations, Dr. Inchera. Is she in Dr. Inchera?
No, no, Dr. Aparna.
Dr. Aparna. Many congratulations, Dr. Aparna. I'm sorry. From
Thank you,
which
ma'am.
place you are working?
Ma'am, I'm working as oculoplasty consultant in Chaitanya Eye Hospital, Trivandrum.
Okay. Keep it up. And
Thank you.
best of luck for the next quiz master.
Thank you, ma'am.
Please appear for the next quiz also. Okay.
Okay, thank you, ma'am.
Dr. Shruti? Shruti Nair. Yes. You are at which place?
We're from Jipma, Pondicherry.
Okay, okay. Dr. Richa?
Hi. Hi, congratulations. I'm sorry, I didn't catch where you guys are from.
You are not audible.
I think
You're not
Jipner
audible.
Pondicherry is what they're
They
saying.
said yes.
Oh, hi, congratulations. That's great. Which year are you guys in?
Final year.
Final year, of course. Uh, lots of luck for your exams. You guys are doing really well. Jipmer is a great place to study. How are you liking your college?
Really great.
Yeah.
Really good curriculum.
Great. So all the best for your exams and make sure to, do a fellowship post PG as well. It's pretty important these days. Okay. But all the best and all the best for the next round as well. Yeah.
Dr. Richa, you are publicly asking about how they liking their college or not. So
They have to give diplomatic answers. That's okay.
yeah.
That's part of residency, no?
That is
Yes.
also part of your
The
residency skill,
training,
like the
yes.
CV building, how to answer very tricky
Such
questions.
questions.
Brain teaser. This was the real brain teaser.
This is a brain teaser as well.
So, Dr. Pramila. Dr. Pramila Das. Sai, any other winners?
No, madam.
Okay. Okay. So with this, we conclude today's quiz episode. So I thank Dr. Khushnood ma'am, Dr. Richa, Dr. Ankit sir, Dr. Abhiraj, and Dr. Anuradha ma'am for all the help and for all the beautiful questions. And thank you to all the mentors and my colleagues and our dear PG students for all this. So we'll see you on 31st of, I think 31st, yes, 31st of January. Okay. That will be our 6th episode at same time, that is 8 p.m.
Thank you, Shilpi. It's a good
Thank you.
program. Thank you so much.
Okay.
Thank you, Dr.
Good
Shilpi.
night.
Yeah.
Okay, good night.
Yeah.
Good night. Good.
Good night. Thank you, Dr. Shilpi.
Bye. Good night.
Good night.